Good evening. So thank you very much for inviting me for this evening. So as you may all understand, that controversies are a very essential part of life. Without controversy, we cease to exist in this planet. Because the controversy brings kind of stress, tension, am I correct? And with this tension and stress, your blood pressure goes up. But we need to reach to a consensus to this stress or tension and controversies, which is sometimes I find it a bit tough and sort of difficult to reach to some consensus in controversies. But nevertheless, I have to talk to such topic, what is controversies to consensus in management of hypertension. It's very intriguing for me to understand that how to approach this problem. So I thought that this is the sort of quite late in the evening, and tomorrow morning, early morning, I have to go to Mumbai. So let me see sort of whether I can make some sense out of this topic. So the outline of this talk is hypertension, Indian scenario, history of blood pressure measurements, ambulatory blood pressure monitoring, with just a couple of slides, guidelines, trials, special case, hypertension, diabetes, and sort of duration, sort of chronopharmacology means at what time the drug has to be given, and eventually conclusion. But the stress and tension was there last week. I'm sure, Dr. Banerjee, you remember last week there's a lot of tension all over the world. Am I correct? This was last week, world was in tension. So, and I was there at that time, and I was sort of there, sort of listening to the debate, the third debate, and there was a lot of tension. I was not quite sure of the blood pressure at that point of time of the country. This week, there's a tension in India. So, and all this kind of thing, when it started, you can easily imagine the blood pressure of our neighbor. And some of our sort of friend in our neighborhood country has gone into ventilator probably because of high blood pressure. But taking all these points together, what is important, if you have stress on the road, crime, if you have sort of demand for job, for unemployment, and eventually that causes a situation called arterial hypertension. Arterial hypertension is a unique example of what I call is medical empiricism. The reason being, the cause is unknown, but if you treat, that is effective. It's interesting, isn't it? So, and that is what is interesting. So worldwide, hypertension continues to remain a major problem. And if this is the case, so what is then hypertension? What is it exactly? Is it just a number? And if this is the number, so what is that number? So we call hypertension. We don't call hypertension to someone whose blood pressure is 120/80. But we call somebody who's having hypertension when the blood pressure goes beyond 140/90. So what happens then in between? What is there? So if the situation is something like this, between the two is called pre-hypertension. But basically the fact is that hypertension, whether it's a disease or just a number, so if you cross beyond some number, you get some disease. If you come down from that number, you're normal. Is it like this? We don't know. So in the next sort of 20 minutes, let us going to talk on that and try to understand that what is the whole objective of treatment of hypertension. So point is, once the blood pressure is 160/90, physician used to be satisfied. So are you going to be satisfied that blood pressure is 160/90? Go home, take rest? We don't know. So what exactly is hypertension? Is high blood pressure is a number, let's say more than 140/90, but it is not exactly like that. Hypertension is basically a complex syndrome of cardiovascular risk factors and perhaps beyond that. That is what we are trying to sort of define, redefine, redefine, and try to make some meaning out of the whole thing. Even after so many definition and redefinition, we fail to understand that what exactly would be the right thing to do in such a situation. And if you look at the Indian scenario of hypertension, it's much more complex. Because if you see, this is the data, hypertension is uncontrolled and conquering the world, and you'll be surprised that lifetime risk of developing hypertension in human race is 90%. And if that is the case, this is the burden in Asian countries. And you can see clearly that in India, at least more than 25%, nearly 30% population at a point of time is having high blood pressure, which is disturbing. And if this is the case, if you look at the prevalence of hypertension in Indian cities, there's a very nice paper being published in one of our Indian Heart Journal, and it shows that this is the data from Andhra Pradesh, this is the data from Kolkata, a district in Kolkata, and other areas of this country has shown that it is really a disturbing scenario even in our country. And if this is the case, why it is a problem? Because this has been shown from this paper that nearly a good number of this population is getting a cerebrovascular accident in India, in various states, and perhaps in our own city. In addition to stroke, they are also equally prone to get cardiovascular disease, particularly coronary artery disease. And you'll be surprised that a good number of these patients may have something called hypertensive heart disease, which eventually gets degenerated into cardiac arrhythmias. Particularly, like today I saw one patient, very interesting patient, a gentleman comes to me with a background of hypertension for 10 years and was on very erratic dosage of medication. And his niece actually brings a patient to me, and her main complaint was very simple. He says he was fine till 7 days ago, till a week ago, when suddenly became sort of, having some shortness of breath, and he's not well, very unwell. And you'll be surprised that patient actually had atrial fibrillation. So these are the things which we are learning today, that even not only just stroke and heart attack and other things, they are also getting something like cardiomyopathy, cardiac arrhythmias, and so many other complications. And that is what is disturbing us. So the prevalence in India at the moment is somewhere around 30%. In rural area, it is perhaps a little less as compared to the urban area. But in 50 years period, there is a much steeper rise of prevalence of hypertension in urban population as compared to the rural population, which is interesting. And you'll be surprised that good number of these patients, they are not aware of their hypertension status. Many of these patients, because hypertension, many of these patients are asymptomatic. When they go to see a doctor, visit a doctor on some routine consultation, and then they find the blood pressure is towards the higher side. That's how it has been detected. And even if you treat them, there's a good number of these patients may actually not taking the medicine properly. The non-compliance remains an important issue in this group of patients. But you'll be surprised that blood pressure is important, and how to measure it was not known to us was just known to us just less than 300 years ago. And the way to measure blood pressure is to put a cannula in a horse in the carotid artery. Of course, this is not possible today. And much more than that, this is the way this is a picture which is interesting. You just put a cannula in the carotid artery of horse and measure blood pressure. It is just about 100 years ago, just not too long ago, we started measuring blood pressure today. And after that, maybe something like 125 years ago, this is the way we measure blood pressure by an instrument called sphygmomanometer. Sphygmo means pulse, manometer is measuring the pulse. Despite that, even this 125 years time, you will find a lot of fallacies in measuring blood pressure. Still, we are debating that what would be the cuff size, what would be the pressure size, whether mercury. Many of these hospitals today, even in the Western world, they are sort of abandoning mercury sort of BP apparatus, assuming that that mercury can be poisonous for the floor. So that is a bit disturbing. So we don't know. But blood pressure measurement is important because this is a very important step of measuring a patient's clinical condition. But having said that, you'll be realizing that most of the doctors, when we see our patients, our blood pressure is being measured in a very sloppy manner. Sometimes it's being taken by less trained people, less qualified people, and we assume that that's the right kind of blood pressure that the patient is carrying, which is sort of disturbed because that determines your therapy, that determines the outcome, that determines the prognosis. And we sincerely do not measure blood pressure on our own, which is certainly an important factor. People also talked about something called ABPM, it's called ambulatory blood pressure monitoring, which provides an information for 24 hours average blood pressure. I strongly believe of this. Even when I was in United Kingdom, We used to actually measure blood pressure by this sort of ambulatory blood pressure monitoring. Somehow in our country, we don't practice this regularly, although in my personal practice, I believe that this has to be done. I do that. This is important because there are certain conditions like borderline hypertension, white coat hypertension, isolated systolic hypertension, particularly in elderly population, nocturnal blood pressure, resistant hypertension, hypertension pregnancy, much more so because we always talk measuring blood pressure for hypertension, we completely forget that hypotension is an important phenomena where pressure has to be measured. So these are the situations when ambulatory blood pressure monitoring helps. And ambulatory blood pressure monitoring, if you find the blood pressure remains more than 130 by 140 by 90 and awake, and sleeping is 125/65, this is the normal thing, which is interesting. And perhaps much more important is a nocturnal dip, which is perhaps important. This is a kind of standard comparison of guidelines. For example, the blood pressure has to be more than 140 by 90. Nowadays, there is some kind of I would say that this European group has said that, well, in elderly population, you can give additional 20 millimeter systolic blood pressure. That's probably an acceptable thing. How to treat? There are various ways of treating, sort of step care therapy, guidelines. I think the simple way of treating blood pressure is, of course, you have to give some lifestyle modification, reduction of weight. Obesity is an important component. Some dietary modification has to be done. The comorbid factors has to be taken care of. If you have patients of osteoarthritis taking a lot of painkiller, that has to be taken care of with proper advice. But simply, the treatment of hypertension with medicine or diet or with pills or tablet is A, B, C, and D. A is something like ACE inhibitor or angiotensin receptor blocker, ARB, B is beta blocker, C is calcium channel blocker, D is diuretic. So whom to choose, what to choose there is no real sort of hard guideline, you have to do that only. It is not like a school and headmaster is talking to the pupils that, well, you have to follow this. You have to judge the case and choose one of those which is the right thing at that point of time for that particular patient. So the right kind of judgment for the patient is very important. But to make it more simple, if you've got a patient who is relatively young patient, then try to choose something like ACE inhibitor or ARB as the first drug. Try to avoid beta blocker unless the patient is having a lot of anxiety or the patient is having coronary artery disease. Elderly person, you go for calcium channel blocker, something like nifedipine or cilnidipine, newer group of drug, or maybe diuretic, particularly chlorthalidone could be a good combination. As you move up further, depending upon the control of blood pressure or the status of the blood pressure situation, you may have to add some other drug, like you can add A on top of C, C plus D. You can sort of combine all of them together. In addition to this, there are other drugs, something like alpha blocker and some more complex drugs can be added depending upon the clinical situation. So, but to make it simple, to start with A for young people, C for elderly people, D, something like if you think that this patient may be benefited by giving diuretic, maybe chlorthalidone may be a better option. We used to give hydrochlorothiazide, but there is not much of difference between the two. Only thing probably marginally, chlorthalidone has got some superiority as compared to hydrochlorothiazide. Beta blocker to be given to those patients where anxiety plays an important element of hypertension, and of course in patients of coronary artery disease having hypertension, beta blocker definitely would be the right kind of drug. Fixed dose combination is also can be considered, particularly if your patient is having requiring more than 2 drugs because of blood pressure. Rather than giving 2 drugs, you can give 1 drug. The great advantage of giving 2 drugs in one, like polypill, is compliance, because the compliance definitely improves, and of course the cost, especially in Indian scenario, when most of the patients they buy from the pharmacy, it will be cheaper. In fact, nowadays the government has taken special steps that if you have certain drugs and if you combine them together, the cost actually comes down. So that as an advantageous for our practicing physician for patients having hypertension. So fixed dose formulation should be considered. Risk factors such as hypertension, dyslipidemia, obesity, insulin resistance tend to be clustered. A multi-drug fixed dose combination pill or polypill might be a very useful tool, particularly in Indian scenario, which may reduce the blood pressure and at the same time may protect the risk factors of cardiovascular disease. There are some trials which is going on, and hopefully we will be able to come out with more answers toward these questions. The Indian guidelines still recommend beta blocker as an agent, particularly in young individual and coronary artery disease. And as I said earlier, chlorthalidone is now widely available, and we are actually prescribing it, perhaps a little better as compared to hydrochlorothiazide, because hydrochlorothiazide has two important side effects. One is it causes a little bit of hyperglycemia and hyperuricemia. So chlorthalidone is not free from those side effects completely, but certainly hydrochlorothiazide is a little more sort of complicated as compared to chlorthalidone. Chlorthalidone, I would say, a little sort of better drug as compared to chlorthalidone. Beta blocker, the two large trial. This is very interesting. I'm sure many of you may be aware of that. That initially beta blocker used to be the kind of first line or second line of drug in hypertension, but these two trials, LIFE study and ASCOT BPLA study, clearly shown that ARB is an effective drug as compared to atenolol, and ASCOT BPLA study has shown fatal and non-fatal stroke or total cardiovascular events and procedures, and all-cause mortality was lower in amlodipine-based regime as compared to atenolol-based regime. So obviously, to treat hypertension, we have to change our understanding, we have to change our views to treat hypertension. How do you do that? Because we may have to consider in certain situations that beta blocker, for example, some of the beta blocker, like in addition to beta blocking, they got an additional property of vasodilating. For example, like intrinsic nitric oxide release may help to cause local vasodilatation. Somebody who actually needs a beta blocker for hypertension, but at the same time may take an additional advantage of local vasodilatation, maybe a nebivolol could be a better option. A lot of my patients of coronary artery disease are getting beta blocker and vasodilating effect of nebivolol, and is working very well, because the beta blocker problem is that beta blocker actually causes peripheral vascular disease. It enhances peripheral vascular disease. Local vasodilatation at times may prevent this peripheral vasodilatation, and therefore may be very useful in patients of having hypertension with coexisting peripheral vascular disease, where the coronary artery disease there, and you need to prescribe a beta blocker. If you give a beta blocker like metoprolol to a patient suffering from peripheral vascular disease, then peripheral vascular disease may get worse because of concomitant treatment of metoprolol. If you give them a beta blocker which has got a local vasodilating property, that certainly will not exacerbate the local peripheral vascular disease, which is very, very useful information. We all know that this vasodilating beta blocker, often known as third generation beta blocker drug, nebivolol, may be particularly suitable as a first line treatment of hypertension. It may also be a treatment guideline to recommend a third generation vasodilating beta blocker as an option. This is a fantastic trial called SPRINT trial. I'm not going to discuss the trial in detail. The hypothesis of the trial is the cardiovascular composite rate is lower in patients having no diabetes if you treat them, and the outcome was to ensure that patients do not develop much of myocardial infarction, and there is not much of acute coronary syndrome, acute decompensated heart failure, ADHF, or cerebrovascular death. It has been shown that intensification of treatment in a very regulated manner clearly improve the primary outcome, which is the reduction of myocardial infarction, reduction of acute coronary syndrome, reduction of stroke, reduction of ADHF, which is acute decompensated heart failure, and total cardiovascular mortality. So it is important to understand these patients about having higher blood pressure do require intensive treatment to reduce the incidence of cardiovascular death, to reduce the incidence of stroke, to reduce the incidence of acute coronary syndrome and myocardial infarction. So intensive treatment has clearly shown 25% lower risk as compared to non-intensive treatment. The SPRINT trial concluded the treatment effect is similar in 6 pre-specified group interests based on age, sex, race, and baseline systolic blood pressure. Overall benefit of more intensive blood pressure lowering exceeded the potential for harm. So many people may think that intensive treatment may actually jeopardize, particularly the renal organs or even the cardiovascular organ, which is no longer true, because in certain group of patients, if you really monitor the blood pressure and be very sincere and treat the patient not aggressively but intensively, then you may actually improve the outcome of the patients. So the guidelines should change as stringent. Now the question is, so are you really targeting towards 120? If you really get into the trial itself, it has been shown clearly that they have not actually targeted 120. They found that many of their patients may not achieve that 120 figure, but their pressure was 121, 122, 133. But clinically, they actually remained well. The incidence of primary outcome like myocardial infarction, acute coronary syndrome, cardiovascular death, stroke, they were far less in this group of patients as compared to those patients who were not treated so intensively. So the clues from SPRINT trial, the special recommendation, the chlorothalidone was prescribed, amlodipine was the drug of choice, beta blocker is considered to be less effective, preventing cardiovascular death, but definitely for patients with coronary artery disease, beta blocker has to be prescribed. The second trial is HOPE-3. HOPE-3 was presented last year in Chicago in American College of Cardiology meeting. In fact, I was there in that particular meeting and representing sort of as one of the faculty members. And we are talking of the hypothesis, very interesting. This is the group from Salim Yusuf and his team. They actually presented the data, and they have shown that the composite of death from cardiovascular cause, non-fatal myocardial infarction, non-fatal stroke, resuscitated cardiac arrest, all those things are clearly being taken care of. And if you treat those patients with antihypertensive drug, particularly they have isolated patients of having intermediate cardiovascular disease risk profile. I'll just quickly take you through this. This is very interesting. In the subgroup of upper third of systolic blood pressure more than 143 or let's say 145, active treatment group had normally significantly lower rates of outcome than placebo. So the treatment is important. You can't ignore the treatment if the blood pressure is more than 140. You have to treat, and if you treat them, you actually get benefit out of this treatment. So this is the HOPE-3 pays special attention to proper blood pressure management, which essentially means for all physicians, junior, senior colleagues, the simple take-home message this evening for all of you is, if you find your blood pressure, your patient's blood pressure is more than 140, just don't say that go home and take less salt. That is not the right advice. It has been shown again and again by many trials earlier and recently by HOPE-3 and SPRINT trial clearly that if the blood pressure goes down below 140 systolic by your treatment, by your prescription, that particular patient is going to have less cardiac event. That particular patient is going to have less myocardial infarction. That particular patient is going to have less acute coronary syndrome. And that particular patient is going to have less stroke. So don't take a figure of more than 140 casually. It demands treatment. You treat the patient. A very simple take-home message from HOPE-3. Because a lot of argument came in. Even I was there. It is a breakthrough session, and a lot of argument was there, and that is the message. The authors clearly says that the data are compatible with the hypothesis that treating persons without cardiovascular disease who have a systolic blood pressure above 140 millimeter appears to be beneficial, but treatment would not be of benefit and may be even harmful in patients with lower systolic blood pressure. So this message has to be very clear to all physicians. I'm just going to finish my talk very short, in next sort of few minutes. But just a single case that if you get a patient like diabetes, hypertension, or chronic kidney disease, what are you going to do? So you look at the target. Now I'm sure that many of us, even the Dr. Jyoti Dev and others, you all remember, we had a lot of meetings, even remember Johannesburg and other places. We used to talk that in diabetic group of patient, we have to treat the patient with systolic blood pressure less than 130, isn't it? That's gone. It's completely gone. That is what is the beauty of medicine. Medicine is such a wonderful specialty when every day you are a student. You never sort of can be a teacher because it changes all the time. What I'm talking today, tomorrow is rubbish. Very clear. So that data is completely thrown off into the bin, understanding that if your blood pressure is even diabetic group of patient, the blood pressure is not that just, you can just go leisurely. It need not be very aggressive either. So that is what is important. So the take-home message for this, in accord blood pressure trial, where they have taken diabetic group of patient, and even creatinine was not more than 1.5, all this trial has shown, this is a fantastic trial, shown that the targeting systolic blood pressure 120 millimeter marker as compared to 140 did not reduce the rate of a composite outcome of fatal and non-fatal cardiovascular events. We used to talk, I gave a talk many times in many places, in this country and abroad, and probably said that in diabetic group of patient, your blood pressure must not exceed 130. You should be very aggressive. But in last year, it turned out to be rubbish. But of course, it has to be 140 as of now. So the message is as of now, because the HOPE-3 has actually created a new understanding of the therapy of hypertension, and that is what is the ACCORD trial. So non-diabetic adult with coronary artery disease, the aim for 11380 is only applicable for those diabetic and hypertensive patients where there is an albuminuria. So diabetic patient, hypertension, no albuminuria, just treat like any other hypertension and measure the target at 140. But if the pressure is there, if the diabetes is there, and there is albuminuria, probably 130/80 would be the right kind of target as of now. So, is it a simple mathematics? We don't know. I'll ask you a simple question. Is it like, ask you a simple question. Like, let us say, this is a sort of, our Indian Bollywood film actress. Sushmita Sen minus 1.2 feet. What is the answer? Anybody? Anyone? What is the answer? 4.7. Yes, anybody from here? 4 point? Who said that? Raise your hand. 4.8. What is feet, inch? Feet. 4.8 feet. 4.4. Anybody else? Huh? Aishwarya Rai. Who is that? Oh, good. Not bad answer. Anybody else? Last option. The correct answer is Sushmita Sen minus 1.2 feet. Answer is Salman Khan. So point is that medicine cannot be practiced like mathematics. There is a lot of logic, a lot of understanding, your experience, and defining, redefining, and refreshing your knowledge, and then see what is the best at that point of time. Because we are treating, I'm a cardiologist, but I don't treat heart. I treat a human being. Dr. Banerjee is an orthopedic surgeon. He doesn't treat only knee joint. He treats a human being. So the treatment of a physician, we are all physicians. Treatment of a physician to human being is completely different as comparing treatment of a doctor by a heart, a coronary artery is just fixing a stent. That is not the way physician should treat. Should be very clear about that. Finally, that when you prescribe a drug, when you're going to give drug, morning, evening, or in the daytime, we don't know. I prescribe morning and evening. Some other doctors only in the evening. No. Why you are writing doctor only in the morning, not in the evening? Because today's sunrise was at 6 a.m. No logic. And he says, so why you are writing at 7 a.m.? This tablet has to be taken because my teacher used to write at 7 a.m. Why your teacher wrote at 7 a.m.? Because his teacher used to write at 7 a.m. There's no logic. Let us just look at the same prescription in a scientific manner and see what exactly is the right thing to do. That is what is known as chronopharmacology. And it has been shown today that the MAPIC trial has clearly shown that if you give an antihypertensive medication in the daytime and in the nighttime, it has been shown that evening prescription, it is not a randomized control trial. It is just a kind of sort of information collected from some registry data. And they have shown that if you give a medication in the evening as compared to the dose in the morning, the blood pressure reduction is probably better as compared to a morning dose. Then what happens if you give in the morning and evening? We don't know. So, but it has been shown that evening dosage reduces the blood pressure to an acceptable level and probably with an achievable target with a lower risk of total cardiovascular events, cardiovascular death, myocardial infarction, stroke with evening dose as compared to morning dose. So this kind of information triggered a trial, and this is a review by this Cochrane group, to evaluate the administration time-related effects of antihypertensive medication as once daily. No random, so that is the reason many of these antihypertensive drugs today are single dose, So you can actually give in the evening. And there is nothing to do with that, with food, without food. There is no relationship of that. Even then, our knowledge is incomplete because there is no significant difference in overall adverse event. So the trials are there. 2 trials are coming up called time trial and High-Gear trial. It has been shown that this time trial, which is treatment in the morning versus evening trial, and High-Gear trial, they are trying to assess the comparison of morning dose versus evening dose with the antihypertensive medication. We have to wait for another 3 years for the time trial and for 4 years for the High-Gear trial to come to some kind of conclusion. So to conclude, And hypertension remains a condition of public health importance, I rather say public health hazard in India. Methodology to measure acute blood pressure should be given due importance. How to measure blood pressure, whether ABP or kind of sphygmomanometer, one has to discuss about that. ABP, or ambulatory blood pressure monitoring, is a useful tool in certain conditions, as I said earlier. In recent trials have provided useful information for lowering blood pressure further. Usual goal of blood pressure should be followed, that is 140, as I told earlier, and in diabetic group of patients with albuminuria, CKD with albuminuria and hypertension, probably 130 and 80. But blood pressure has to be controlled with medication. If it is 140 by 80, you can't ignore on that. That is what HOPE-3 trial and SPRINT trial. Blood pressure goal can be lowered further in some special population, particularly with comorbid condition like diabetes, chronic kidney disease, and other diseases. Choice of drugs should be individualized, not a question of one drug, not a particular mathematical formula. Till more data emerges, probably evening dose of antihypertensive can be advised. And it is important time that when in India, we should have our own registry. I actually got a hypertension clinic. On one of my weekdays, we collected data of hypertension patient and try to sort of collect with my postgraduate student and try to present in a lot of national meeting and some of the international meeting. In fact, our hospital is now being tied up with the American College of Cardiology with my effort as ICO International Clinic Center of Excellence. We're actually taking our data there next year in 2017, and on 2018 onward, we'll getting a sort of special place to present our data. Thank you very much for attention.
Yeah, thank you so much, sir. What to say? Because it's more important, not only important to treat human being the way you have talked about, but at the same time, when to treat, how to treat, which agents needs to be used, and in which circumstances it's to be treated, that is most important. And aptly you have covered all the aspects. And I think though there are so many controversies, but there are clear messages for managing treatment. But I can't leave you without the questions, because I feel that there will be so many questions on the floor, because though it's a hypertension is a very common one, but it's complicated also and differently treated by different people. So I would request all the questions coming in your mind, please, there is a time to address it.
If you just take a microphone, sir. I thought there will be only one question. What time is the dinner?
How would you treat isolated systolic hypertension in elderly individuals?
This is a good question. The isolated systolic hypertension called ISH. ISH trial, there's a SHAPE trial, long time ago, systolic hypertension in elderly population. SHAPE trial actually used to, the SHAPE trial taught us that in elderly means at what age? So is it 70 plus, 80 plus, 90 plus, 60 plus? What is the age? What age you think it is systolic hypertension, elderly? What is elderly in your definition? At what age?
Age 70 years.
70 years, right. So even that elderly age is changing. 60 years and above, sort of, you're no longer elderly. So in Western population, I don't know what is the elderly. Nobody calls that I'm old. So it's beyond 70 years, the drug of choice, if everything is otherwise uncomplicated, the good drug is diuretic. That is a good drug. That is probably a small dose of chlorthalidone, 6.25 or 7.5 is a better drug. Is a better drug for your hypertension. Otherwise, if your comorbid condition is there, like coronary artery disease or even chronic kidney disease, then of course the treatment may change. But even then, ARB is not a bad choice in this group of patients. You have to just individualize the situation and treat accordingly. Beta blocker, if some of these patients may have a bundle branch block, may have conduction disorder, then of course you may not advise beta blocker in this group of patients.
Do you recommend cilnidipine in chronic kidney disease?
Is a good drug, cilnidipine, because the cilnidipine is a calcium channel blocker. It blocks two receptors, both L and M receptor, which is not there with amlodipine. Cilnidipine is a better drug because since it blocks both L and M receptor, is a better drug as compared to the amlodipine in chronic kidney disease. Only disadvantage of cilnidipine is it is not a very potent, it's not the potency of antihypertensive effect is not as good as amlodipine. There's a third generation, another drug is coming up that reduces 3 receptors. That may be a better drug, which we can talk in another
I think
forum.
the dose of 10 milligram is not sufficient.
Correct, exactly. Cilnidipine stain is not a very efficient, not a very potent drug. Yeah.
After the sprint trial, should we change our target blood pressure? Because way in which blood pressure was measured in the sprint trial, 120/80 is equivalent to 140/90 in office BP. So should we change our target after sprint trial? Because so many benefits.
Good, very good question. Actually, sprint trial, if you read it in detail, it doesn't really say that you have to reach the target. What it says is that your intensification of the treatment should be such that do not ignore having a blood pressure above 140/90. That is what is the single message. But when you treat this group of patients, you actually achieve a target nearly 120/80. But large number of those patients actually did not achieve 120/80. But the benefit still was there. The sprint trial take-home message is conclusion. If you read the whole paper, the conclusion, the paragraph is very simple. Conclusion paragraph did not talk about the reaching a target by a number. What it said that if you treat them intensively and monitor their blood pressure, you will actually see that the blood pressure has come down below 140/90. By achieving that sort of level, they are actually protected from cardiovascular, cerebrovascular side effects. So it is the outcome-driven sort of therapy rather than a number-driven therapy.
Sir, a combination of 2 drugs, cilnidipine and telmisartan, will be better?
No, sorry, I can't see what sort of question. Oh, right. Yeah, okay, sir. Okay, madam. Yeah, go ahead.
Combination of 2 drugs, the cilnidipine and telmisartan, that would be better than only cilnidipine?
Depending upon your clinical condition. For example, somebody having chronic kidney disease and creatinine is probably rising. And in those situations, telmisartan may not be the right choice. Because ARB is a good drug even in chronic kidney disease, provided the creatinine level doesn't go up. So if you find that the creatinine is coming down, with your telmisartan combination is a good drug. But if you find that creatinine is going up, then the cilnidipine with telmisartan combination should be taken off. Only cilnidipine with a higher dose may be a better sort of option. But when you treat with a higher dose, the chance of having sort of pedal edema, and that can be taken care of by adding diuretic, something like torsemide.
Maximum dose?
Of what? Of
Cilnidipine?
cilnidipine. You can go actually as high as 40 in chronic kidney disease, 40 milligram, but 40 milligram causes a lot of sort of leg edema. So what I do normally, when I increase the dose of cilnidipine in a rising creatinine, I add torsemide. That takes care of the leg edema, at the same time blood pressure becomes normal. You got one more comment.
In sprint trial, BP was measured, patient was sitting in a silent room alone, BP was measured by automated instruments. So that scene in real practical life we hardly get.
Correct, exactly. I agree with you.
So
In fact, I'm very happy, simply glad that you raised this point. In the original sort of presentation of sprint, that slide was there. I deleted that here because this is not applicable in our everyday practice. You're absolutely right. Absolutely right. Sort of, otherwise you have to take all our hypertensive patients to some religious place and a temple, and then sort of first you finish the religious rituals, then measuring blood pressure. This is completely non-practical way of doing it. I entirely agree with you.
Sir, very good evening. Thanks for a beautiful lecture. I'm calling from the last row. Sir, nowadays we are getting a lot of patients, young individuals with isolated diastolic hypertensions, uncomplicated cases, 125 by 100, 130 by 105 in ages around 30, 31, 32, 35. Now, what difficulty we face in treating this isolated diastolic hypertension? If we employ one particular agent, which tends to lower the blood pressure, the systolic also comes down. Systolic also tends to come down. So I've got 2 questions for you. Whether to choose a monotherapy in this case or a dual therapy, dual agent, fixed dose combinations. And if so, what is the appropriate drug to try out first in this case?
Very good question. In fact, before I think, sorry, doctor, can you just remind me your name?
Dr. Amitabh Datta, you know me pretty well.
I know you. Just for the others' information. So I know Dr. Datta very well, actually. Good that you raised this point. The question is very good question, that if the diastolic blood pressure is elevated, systolic blood pressure just to the higher side of normal, isn't it, Dr. Datta? Why can't you stand? Why, sort of the systolic blood pressure is to the higher side. What are you going to do? Is it a disease or not? You will be surprised that this kind of situation, isolated diastolic blood pressure, usually happens in rather younger individual. And this group of patients are very anxiety prone, very anxiety prone. So what happens here, if you do not treat them, the chance of developing cardiovascular complication is sort of like myocardial infarction, even stroke is less. What actually happens here, because of persistently elevated diastolic blood pressure, the heart is stiff. The heart is an organ which needs to relax and needs to pump. So the is called relaxation abnormality. A lot of these sort of young individuals, if you do an echocardiogram, you actually find that heart is stiff and there's a diastolic dysfunction. And persistent stiffness of the heart actually causes indirect left atrial enlargement, make them very prone to get cardiac arrhythmia. And the myocardial fibrosis there. So the drug in those group of patients, first drug, what you should do, you should try to reduce the afterload. If you try to reduce the afterload, the drug which is very useful in this group of patients is something like a calcium channel blocker. But amlodipine may be very strong, because if you give an amlodipine, the blood pressure will drop. Systolic blood pressure drops significantly. So that is a problem. You can actually try something like a small dose of cilnidipine, which is a good sort of drug in this group of patients. But what happens is that is not sufficient to cause the diastolic blood pressure to drop down. You can probably add a small dose of beta blocker, and in those group of patients, try to avoid the beta blocker which causes peripheral vasoconstriction. Try to avoid that. Maybe a small dose of sort of nebivolol would be very nice, because that has got an associated vasodilating effect. So nebivolol, because of the vasodilating property, it will actually decrease the diastolic blood pressure. And because of the sympathetic blockage, it will actually reduce the sympathetic effect like anxiety, stress. It's a wonderful combination. And just to add further to your question, I'll tell you, last 3 days, I got about 10 to 12 young individuals. All of them were around 40-ish. And all of them were actually in share market. Because of the currency sort of crackdown on last few days, all of them, they landed to me with a blood pressure 105. Today I saw 2 patients. And all these patients, I prescribed nebivolol and cilnidipine, and 3 of them are actually doing very well. Some of these patients may actually require concomitant small dose of ARB. That will depend upon your personal sort of experience and of course some follow-up. I think I'll start first with a small dose of cilnidipine and small dose of beta blocker, nebivolol something like 2.5 milligram. Call them up in about 72 hours time and see the blood pressure, diastolic blood pressure response, and then see. And then probably what you can do after the initial, they feel extremely uncomfortable. You can't believe. Their symptom is they're symptomatic. They feel out of breath. Because of stiffness of the heart, they climb stairs, they go, and they feel out of breath because the heart is stiff. So the moment you give, they feel relieved. And what you can do probably before commencing another drug or adding another drug, you can actually do an ambulatory blood pressure monitoring and see what happens to the nocturnal blood pressure. All this group of patients, young individual, with the diastolic blood pressure elevated, systolic blood pressure just above the normal, the nocturnal dip of ambulatory blood pressure monitoring goes off. So beta blocker, nebivolol, and cilnidipine takes care of this.
Thank you, sir.
My question is, below what level of diastolic blood pressure is harmful?
Oh, that is a good question. We don't know. Honestly, we don't know what exactly the number of the diastolic blood pressure is bad. I would rather say, sir, we know that it is the 140/90. 90 is the higher limit of diastolic blood pressure. But the question is whether 91 is sort of diastolic hypertension. Answer is I don't know. Neither do I know that whether 92 is a diastolic hypertension. But somebody having symptom with a diastolic blood pressure of around 100 or 98 and is having symptom with a little higher set of systolic blood pressure, I would certainly consider that particular patient to be treated. And the treatment, as I discussed earlier.
No, I'm talking about below what level of diastolic blood pressure is harmful?
Below what? Normal, below 90.
Diastolic blood pressure.
Lower.
Below what level of diastolic?
I got your point. 60 millimeters. It is. Yeah, I'll tell you. Blood pressure is 100 to 140 systolic, 60 to 90 diastolic. So somebody you are prescribing, let us say, like very common thing. You give a medication like one, let us say, you have given nebivolol and you have given amlodipine. Patient initial blood pressure was 150 by say 98. Patient comes, sir, you have given prescription, my blood pressure has come down. What is the blood pressure? Blood pressure is something like 110/70. Should I stop the blood pressure? Then you know what I say? And most of you, and you'll be surprised, you get a phone call over mobile phone. Sir, my blood pressure has come down to 110/70. Should I come down? I make a very simple answer. If the blood pressure is 0, continue the tablet. Because that doesn't happen. So up to 60 is fine, no problem. Diastolic blood pressure, if it falls from 90 to 60, patient doesn't become symptomatic as compared to systolic blood pressure.
But often we face one problem, that systolic blood pressure with 170 and say diastolic is 70, and the patient is already on diuretic. So what will you do in these cases? 170 systolic and diastolic is 70.
Correct. That's what sir asked just a while ago. That this is the patient of systolic hypertension.
No, patient is already on diuretic.
I know that on diuretic patient is still having blood pressure 170 systolic, and second is There are two things you should consider. Firstly, you check his blood pressure. It may not be 170. You should be very sure that this is 170. So this is a group of patient, as he said very rightly. Probably you need to recheck the blood pressure in a relatively sort of in a quiet environment. These are the situations when sometimes we physician do not, because you have to appreciate one very clear thing, that blood pressure measurement is very important, and blood pressure measurement we do very casually, isn't it? Sometimes as your assistant, you can do the blood pressure. You say there's something in the ward, the staff nurse is taking blood. Less trained people are doing it. These are the conditions. When you yourself measure the blood pressure, ask the patient, wait for a while, measure again. Okay. And then also ask the patient to do the same measurement with the same machine at the same time by the same person. You will find the figure has changed. That is very important.
Thank you.
Sir, one question. Control of lipids in hypertensive patients.
Oh, good question. Control of lipid in hypertension patient is no different. Firstly, I have to tell you one thing. Again, for the lipid, that aggressive lipid lowering therapy is going away. It is no longer that. First, you know the dietary thing has gone. It is no longer the diet cholesterol doesn't mean that your own cholesterol go up. That is rubbish. But cholesterol is important, especially if you have a patient of hypertension and coronary artery disease. Then the lipid has to be treated the way you treat lipid. That is just simple lipid lowering formula. And you know that Indian guideline has already been published. I'm one of the authors in that Indian guideline. So you can actually go through the website and you'll find my name. And we actually created Indian guideline for the treatment of lipid in Indian population.